Good time of day, everyone. My name is Alex. I will be your host for today's episode of Rack Hospital Podcast. Today, we're going to be discussing BPH. What is that, you might be asking? Well, today, we're going to explore this condition and answer all the questions that we might have with the help of Dr. Karthik Rao. He's a consultant in urology with over 10 years of experience at Rack Hospital. Thank you for being here, Dr. Karthik.
Thank you for having me.
How are you?
All good, thank you.
Amazing. So, let's start with the basics. Let the audience know, what is BPH? What does that stand for?
So BPH is a short form for something called as benign prostatic hyperplasia. So benign prostatic hyperplasia just means it's an enlargement of the prostate gland
Mm-hmm.
and it's not cancerous. So basically BPH, you don't have to be worried if the doctor says that you have BPH. It doesn't mean that you have cancer. It just means that you have an enlarged prostate.
Okay, so benign, that means non-cancerous.
Yes.
Okay, so who should be concerned about that? What's the primary
Yeah.
audience of that?
Basically, the benign prostatic hyperplasia affects people who are beyond 50 years of age.
Okay.
Nearly 50% of our patients with BPH come to us between 50 to 60 years of age.
Okay, so I shouldn't be concerned about that for now.
You shouldn't be at least
Okay.
for a few more decades. Yeah.
Okay, that's good. That's good to hear. So, okay, so around 50 years old, that's when you start to have maybe symptoms. What kind of symptoms might those be?
See, symptoms of an enlarged prostate, basically, I need to tell you what is the prostate gland and where is it situated.
Yeah.
So basically, the prostate gland is a gland seen only in men.
Mhm.
It is at the outlet of the urinary bladder. So basically, it helps in our reproductive function, where it helps in maturation of the sperms.
Okay.
That's the basic function of the prostate gland.
Mm-hmm.
But as we grow older, because of hormonal changes, the gland starts increasing in size. So when the gland starts increasing in
natural,
size, yeah, that's natural.
Okay.
When it starts increasing in size, then it will cause a block to the outflow of the urine,
Mm-hmm.
right? So patients can come with different kinds of symptoms. We divide them usually into something called as obstructive and something called as irritative symptoms. So the obstructive symptoms are like patient will have difficulty in initiating the act of urination. He may take a longer time to pass urine. He may have a slow stream of urine, and he may have something called as an incomplete sense of urination. He may feel that he's still having some urine left after he has passed urine. And a very, very common symptom here, especially, is something called as post-void dribble. That is, after he passes urine, there are still few drops coming out. So these are all the obstructive symptoms which most commonly people come with, and something called as irritative, and it's irritative for that particular reason. It's called irritative because for that particular reason, that patient has urgency, he can't control his urine, he may sometimes leak urine, he may have increased frequency of urination either during the daytime or more commonly in the nights, and then he can have something like a burning sensation while passing urine. These are all the irritative symptoms which the patients can come.
So they're called irritative, not because there's some sort of
Symptoms are irritative to the patient.
to the
It's
person.
not to the doctor.
It's just irritate. Okay, because I've heard in medical terms, especially irritation usually concerns
Yeah,
skin. It's
understood.
like
Yeah.
yeah, but this is just psychological. Okay, that's interesting. So okay, so basically only after you're around 40, that's when you should start maybe seeing the doctor, right, about this or concerning. Like, should you be regularly
Basically,
checking?
the myth is if you have a large prostate, you will have symptoms. No.
Mm-hmm.
So basically, you need the prostate to block the outflow of urine when you have symptoms. So if the patient in a routine uh, health checkup, or say usually you start your health checks probably by 40 years of age. If you have an enlarged prostate of say a 25 grams or a 28 grams or a 30 grams, just to name the number, but he doesn't have any symptoms, then probably we needn't evaluate him further. So symptoms are very important when you evaluate benign prostatic hyperplasia.
Okay, so there could be different sizes, but
Yes.
only if you actually have a problem, then you should.
Yes. What I mean to say is a person with a 30 or a 40 gram prostate can come with retention of urine. That means unable to pass urine at all. And somebody with say a 75 or a 100 gram prostate may not have any symptoms. That all depends on how much of the urinary passage is getting blocked rather than the size of the gland per se.
Okay, so only if you're experiencing these certain symptoms, that's when you should
Then you get evaluated. Yes.
okay, concerned about it. Okay, and so how would you actually end up diagnosing someone with that? What's the process?
So basically, we have a symptom scorecard, which is called as an International Prostatic Symptom Score. which is in our history.
Mhm.
So basically, history is the patient's story.
Okay.
His
Yeah.
story. That's what is history. So the patient gives his symptoms, and we just put down the numbers on the chart, and then we physical examination. Again, it's very important. Yeah, it is scary for the patient though, because I need to put my finger into
Of course. That's
the anal region to feel the prostate. So that gives me an indication how big the prostate is.
yeah. No one wants to
So that
experience
is,
that.
yeah, okay. But then
But you,
that's a saying. Yeah, okay,
it's
okay, it's
necessary.
okay, it's okay. That's necessary. And once we clinically feel that the patient has an enlarged prostate, then we go ahead with different tests. So basically, an ultrasound is essential to check what is the size of the gland. And one more essential part of the ultrasound is what something called as a post-void residual urine.
Mm.
That is how much of urine is left behind after he passes urine.
Okay.
Okay. And the next is we have something called as a uroflowmetry. That is, we have a machine where the patient just goes and passes urine in the machine, and we get a graph which tells us whether his flow is good or not.
Okay.
And then yes, we need to rule out his infection in the urine. We do basically a baseline PSA for all patients of enlarged prostate. That is a prostate specific antigen, which is a cancer marker. So we, as a baseline, we do it for all patients.
Okay, I see. You mentioned something about a myth. What are some? Are there any like common myths that people have about this condition? That
Yeah. So enlarged prostate, people think it's cancer. It's not, right? So that is
they jump
one.
to the worst conclusion.
Yes,
Yeah.
that's the biggest myth. The second, as I've already told you, is the size of the gland not necessarily compares with the symptoms with the
Mhm.
patient. So better to get evaluated by the urologist before you even consider any form of treatment at all.
Okay.
And people say, can I prevent it with some food? Can I, if I take specific type of food, can I prevent a benign prostatic enlargement? Probably not. So
So there's no preventing it at all. Is it just a natural occurrence?
yes,
That
it's a natural occurrence. I don't think you can, with any diet specifically, you can't change your diet to say that if I change this particular diet, I will not get an enlarged prostate, and it doesn't happen. So
okay. But is there some way, at least maybe not preventing it, but somehow in the future?
basically, you can
Yeah.
control your symptoms like lifestyle modifications,
Mm-hmm.
which can help you not at your age, probably beyond 50,
Okay.
to say reduce the frequency of urination by reducing caffeinated drinks like
Okay.
Coke, or reducing the amount of coffee you take,
Okay.
restrict,
Caffeine is not.
yeah, restricting the fluids beyond 6 p.m. These are all the lifestyle changes which you just control the symptoms of prostate.
So
You
just
can't,
to
you
reduce
can't, yeah,
the pain you go through,
yes,
essentially.
you don't have any lifestyle modifications where you just try to prevent the growth of the prostate. That's not possible.
Okay. But is it so? You say it's natural, and that men over 50 typically have that. But is it that everyone goes through this, or is there?
Not necessarily, not necessarily, not necessarily. Yes, sometimes it could be hereditary, like if your dad had a large prostate, you probably would have a large prostate.
Okay, I'll have to ask him that.
Yes. So, but again, as I specifically said, the gland size and the symptoms may not correlate.
Okay,
It's a good indication that you have an enlarged prostate and you have urinary symptoms. It's most probably due to the prostate itself. So
okay, so the advice you would just generally give to anyone is like when you get to like around 45, 50, just
get your health checks done. Meet the urologist.
and don't drink coffee anymore. Yeah?
No. I'm not against that.
Like
No, not at all.
only if you want to reduce the.
If you have frequency of urination, then you reduce your caffeinated
Of
drinks.
course.
That's it.
Okay, well, so what? Okay, you mentioned treatment options. What kind of treatment options are there, and what is the ultimately the result? Is it just removal of the symptoms?
So basically, it's a pyramid, or it's a stepwise treatment what we usually follow. So initially the patients would be tried on something called as a medical management.
Okay.
So we have medicines, very good medicines, to decrease the size of the prostate and open up the outlet of the bladder so that he helps him to pass urine more freely.
Okay. What medicines are those?
um, we have silodosin, which has come into the UAE market quite recently, and tamsulosin has been there for quite some time already in the market, and alfuzosin is the oldest drug which has been there forever.
They all have the suffix dozen, I think you said.
Yeah.
Is there a significance to that?
What?
The suffix at the end of the word?
Yeah,
for each
yeah,
of
yeah.
those?
It's all it means that all they belong to the same group of drugs, but then the receptors which they act on, like alpha-synuclein and tamsulosin, are general receptors. They act on all the receptors, entire body. So the side effects profile is more, whereas psilocybin is more specific to receptors in the prostate. So the side effect profile is less.
Okay, see. But they're all from the same group
From the
that
same group of
help
medicines.
treat
Yes,
something
yes,
like
yes.
that. Okay, okay. And so outside of medicine, what's the other treatment like?
Yes. So once usually we say, suppose I'll give you two different scenarios. One, a patient comes with retention of urine. That is, he's not able to pass urine. We have put a catheter.
Okay.
Then we start him off on medications. We give something called as a trial void. That is, we remove the catheter, say after 2 weeks
Mm-hmm.
of catheterization. He passes urine well. He's happy with his flow. You can continue the medications. Now, if he's not able to pass urine and then you have to recatheterize him, that is a failed trial void.
Mhm.
Now, this patient probably would not do well with medications alone. The other patients who are not come with retention of urine, but only like some obstructive or irritative symptoms, which I had mentioned earlier, and you give him medications and he's symptomatically significantly better, you can continue these medications, say, for 6 months. And beyond 6 months, the effect of the decrease in size of the gland is not that much. So up to 6 months, you can expect a decrease in the size of the gland by, say, a 25%.
Mm-hmm.
So that's still good enough. So in these two different scenarios, which I said, the first scenario, he would require a surgery. In the second scenario, probably we can continue with the medications for a period of 6 months.
Okay. And so after these 6 months, there's no point in taking the medication, or?
Basically, even if you take the medication, the size of the gland is not going to come down.
Okay, but
We get patients who have been on these medications for years together, 3 years,
mhm.
5 years. Once you, beyond 6 months, you stop the medications and you see how the patient feels. Probably he would be feeling better even without the medication.
So there might be some sort of a like kind of permanent effect after the 6 months that you
No,
don't need
you
medication
can.
or
What I usually tell my patients is you can postpone your
oh,
procedure.
you just wait until
You
okay.
can postpone your procedure. You may not be able to completely avoid any procedure in the future.
Okay.
Future may be a year, future may be 10 years. You can never
Cool.
say.
Okay, that's interesting. Okay, so what would you say, like, because I'm sure a lot of men are out there, they may be experiencing some slight symptoms, it's not like the end of the world yet, but they are starting to, and there's just, maybe shy or something like, they're not like, men don't like to go to doctors as far as I'm concerned, typically because
A
they're like,
urologist is supposed to be an andrologist also. So we are here for
yeah, well,
men, ma'am. We have something called as a man clinic. So
of course.
yes.
It's just, I know typically like there's some sort of psychological thing. A lot of men, they don't like going to the doctors because it's like, whatever
Okay.
the psychology is there. What would you say to those kind of men that are maybe like starting to experience some symptoms when they're about that age?
So basically, beyond 45, if you have any of the urinary tract symptoms which I have talked about, I think it's better to get evaluated. You should get evaluated.
Okay, and then see, is it like, can you maybe calm them down? Like it's not as scary as it might seem.
It's
That
not
they
scary at all.
not scary at all.
Not scary at all.
Is there any, especially let's say in the more severe cases you mentioned how, you go through a procedure of putting a catheter inside. Is that
Yeah.
painful? Is that
See, basically, catheter may not be painful. It is uncomfortable.
uncomfortable?
Yes. Now, if you want to avoid the patient, like I said, if somebody has failed a trial of removal of catheter, then he would require some sort of procedure.
Okay.
So this procedure is again minimally invasive. So I don't have to cut. I don't have to put punch holes in the body. I do something called as an endoscopic procedure. That is, we go in through the urinary passage called as transurethral, and we can do something called as resection of the prostate, which is the gold standard.
Okay.
So that is something called as a procedure called as TURP or TURP in short. Okay. So
TURP.
TURP, that is a transurethral resection of the prostate.
Okay.
So yes, we have energies of like current, that is called as bipolar, or we can use energy like laser when it's called as a laser resection of the prostate. So these two are the gold standards. That means it's been there for time immemorial, and people have got good results with that.
Okay.
These are something called as where you compare. The gold standard is something you compare something else with this.
Of course.
So that is the gold standard.
And if you do that, is that like then for sure you're getting rid of the symptoms and like you don't have to
Yes,
worry about it anymore?
basically it's like, imagine the prostate to be say an apple,
Mhm.
and the urinary passage goes through the apple, right? So we go through the urinary passage, we remove the flesh from inside the apple,
Okay.
and then you have the skin of the apple, which we call as the capsule of the prostate. You don't go beyond the capsule of the prostate because it'll start bleeding.
Mm.
So basically the tissue we remove from inside, we basically open up the urinary passage,
Okay, I see.
helping the urine flow better.
Okay.
So this is what is done in short.
So it's not like that bad at all. It's
It's not that bad.
okay.
He'll be post-operatively he may have a catheter in place for 2 to 3 days,
Mhm.
beyond which the catheter will be removed, and he may experience few symptoms like frequency, a little burning sensation while
Mhm.
passing urine for 3 to 4 weeks, and then once the prostate heals well, then he's as good as normal.
Is there any like let's say pain that comes with it like after the operation, like difficulty walking, I can imagine.
No, nothing
No?
at all. The other myth is patient usually don't go in for surgery because they feel that they will become they'll have leakage of urine, or they start leaking urine.
Mm.
It doesn't happen.
That'll happen. Okay, well that's good. Okay. There's one thing I did just a little bit of research. I've heard of something called Optilume. Are you
Okay.
aware? What is that?
See, optilume is for strictures of the urinary passage. It's basically dilating the stricturous part or the narrow part, and then it is usually they are medicated right now to prevent further narrowing.
Hmm.
Okay, but it doesn't help in the prostate. We have the newer modalities in the prostate. Uh, Basically, the side effects of the gold standard treatment, that is a TERP, is that first the patient would have to have a procedure under anesthesia.
Mm-hmm.
Patient stay in the hospital maybe 2 days. He may have bleeding or blood in urine. He may have to stop if the patient is taking cardiac medications like blood thinners. He would have to stop the medications for these procedures. And very important, and when you asked, men don't show their symptoms earlier to the doctors. We have something called as retrograde ejaculation. That is, the patient will have a dry ejaculate because the bladder neck, or that is the region between the bladder and the prostate, would be resected during a TERP. So
Mm.
the semen will go into the bladder and not come out. So this is known as a dry ejaculate. Doesn't matter because it just mixes with the urine and comes out.
Okay.
But basically, if you need more children, then it's not possible following a TERP.
Okay.
Now, the newer modalities we have in RAC hospital, like we have something called as Resume, which is water vapor therapy, and we have something called as Urolift.
Okay.
Now, what is Resume? Resume is basically you cook the prostate with steam.
Yeah, that
No, it doesn't look that bad. Doesn't look that bad.
sounds interesting at least.
Sounds bad. Okay. So basically, we inject a needle into the prostate and we inject steam. So when you inject steam, what happens is the tissue initially starts, it swells. When it dies, it shrinks.
Okay.
So this is basically what happens in water vapor therapy of the prostate, which is called as Resume.
Okay, so you cook your prostate.
Basically, yes. Basically. But yeah, it's done under anesthesia, so I don't think the patient feels any
Okay.
much of an
Nice.
issue. The other one is something called as Urolift.
Mm-hmm.
Basically, Urolift is a urethral lift mechanism where it's again an endoscopic procedure. We place pillars and we just open up the prostate from inside.
Okay.
The size of the prostate tells us how many pillars we may require. But then this again is a very elegant procedure. The advantages of these minimally invasive procedures is the retrograde ejaculation, which I mentioned, will not be there. It would still be, he would still have his ejaculate. So person who wants to preserve their fertility,
Mm-hmm.
these newer modalities are good. The difference between Resume and Urolift, Resume would need a catheter for a long time, probably for a week or so, whereas Urolift, we may remove the catheter the next day.
Okay.
So these two are the latest treatments available for the enlarged
So
prostate.
these are some of the options that people have.
These are the latest options available.
Okay, so like who would you recommend go through
Basically,
these?
anybody who has a gland size of say 40 to 60 grams,
Mhm.
who wish to preserve their fertility, and not much of complications, like somebody can have stones in the bladder, somebody can have raised deranged renal functions,
Mhm.
like creatinine could be raised. With complications of an outlet obstruction, probably I would suggest still patient to undergo a TURP. But if only for the obstructive and irritative lower urinary tract symptoms, then these modalities are good.
So just so I'm clear on this, I mentioned Optilium. Those are the types of that, or what is that a different one?
Optilium is just a balloon.
It's
It
just
is for narrowing of the passage, correcting the
okay.
narrowing of the passage,
And is that like
not for the prostate.
okay? So it's just kind of like is it a temporary solution, or is it just kind of
It's a temporary solution.
okay? So it's not. It doesn't actually solve the
No.
problem. It's just maybe if you
And Optilium is not for the prostate. If somebody is told Optilium is for the prostate, definitely no.
okay. Because I was searching about BPH
Understood.
and it
Yeah.
mentioned Optilium. Okay, so that's not specifically for that, but it helps maybe with the symptoms of
With
that, or
stricture of the urinary passage.
only that specific.
Yes.
Okay, well that's good. Well, I think that's about all the questions I have. What would be like the last message for the people watching? If someone is having maybe the symptoms, or maybe they know someone who's having them, like their family members, what would you say to them? What should they do in that
Yeah.
situation?
So basically, if you've sat through our podcast today, I think you would the most of the questions of difficult questions of an enlarged prostate would have been answered. So basically, what I'm saying is you don't need to fear the symptoms of an enlarged prostate. There are very elegant solutions right now, very effective medications for the same, and come visit us, and we look after your prostate.
So okay, again, Rock Hospital, Doctor.
Karthik Rao.
Yes, you can look for him there. He'll help you, I'm sure, a lot. Just don't be scared. Don't be too worrisome about this. I guess if you're around 50 years old, everyone goes through that. So thank you guys for tuning in. Thank you for listening to the podcast. See you in the next episode.